Hello, everyone, and welcome to The Wrap, brought to you by Michigan Medicine Headlines. I'm Dan Elman with the Department of Communication.
And I'm Dan's sidekick for the day, Bailey Merzick. On today's episode, we're going to discuss the beta-lactam allergies evaluation service and how it improves patient care at Michigan Medicine.
Now, before we get into that conversation, be sure you improve your knowledge of all that happens in the organization by checking out previous episodes of The Wrap. You can find the shows on iTunes, Stitcher, Google Play, or any other podcast hosting platform. We also release the episodes on the Michigan Medicine YouTube channel and as part of the Headlines Week in Review.
And with that, let's bring in Greg Eschenauer and Raj Ravikumar. Can the two of you first introduce yourselves and explain your roles in the organization?
Yeah, hi, good morning. Thanks for having us. My name is Raj Ravikumar. I am a faculty member here in the Division of Allergy and Clinical Immunology, and I'm the medical director of the beta-lactam service.
Hi, my name is Greg Eschenauer. I'm clinical faculty at our College of Pharmacy. At the hospital, I'm an infectious disease clinical pharmacist, and I'm part of what we call our antimicrobial stewardship team. And I'll sometimes refer to some guidelines or guidance that we produce regarding infectious disease care. And folks can find that at our program website, which is med.umich.edu/ASP. That's Antimicrobial Stewardship Program.
Outstanding. Well, thank you to both of you for joining us today. We're excited to have you. All right, let's start this conversation very broadly. What is the beta-lactam allergy evaluation service, and what types of patients do you serve?
Yeah, so this is a consult service that was first started in August of 2021, and it's staffed by two outstanding nurse practitioners. And we see all patients in our health system and in all age groups. And so this purpose, what the service has been tasked to really do is evaluate patients who have a beta-lactam allergy label. And those antibiotics include penicillins, cephalosporins. And the purpose really of the service is to try and address those allergy labels, which we know overwhelming majority of which, over 90%, are erroneous and patients can actually tolerate them. So our hope is really to try and affect what antimicrobial agents they can receive while they're admitted, either during this hospital stay, but even if we think it may not directly impact them during this hospital stay, maybe it'll impact their care down the road.
So you mentioned the allergy labels, which some people might not know. What are the allergy labels, and what do they mean, and why are they so important in someone's electronic health record?
Yeah, so an allergy label, it's a purported allergy to a medication, and that's documented in that patient's health record. So, I think everyone's familiar with this. One of the first questions that patients ask when they present for medical care, whether it be in the emergency room, at their primary care clinic for routine appointments, for surgical evaluation, et cetera, is whether they're allergic to any medications. And so many of these labels are self-reported by patients in that they either believe themselves to be allergic to a medication or they were told by a provider that they were allergic. And then some labels are also, of course, placed in that patient's health record by providers who witness the patient having a reaction to a medication. In terms of why they're important, so it's kind of a three points to kind of get to solving that question. First, about 10 to 15% of patients have a label of just a penicillin allergy. And maybe I should clarify that a little bit because we'll use those terms a little bit interchangeably. So beta-lactams are a very large class of antibiotics. Penicillin is one of those antibiotics. And since it or its closely related cousin amoxicillin are often the first beta-lactams patients are exposed to, often in childhood, it's often the allergy label that patients present with. But when a patient has a label of a penicillin or amoxicillin allergy, providers sometimes may be reluctant to use any drug in the entire beta-lactam class. Okay, so 10 to 15% of patients, including at our institution, have a label of a penicillin allergy, much less labeled to any other beta-lactam. So at an institution like ours, just, in patients hospitalized, that's 100 to 150 patients a day who have that label, who are actively in our care in the hospital. And as Raj said, though, 90% of those labels of those patients are not actually allergic to, for example, penicillin. And so the label's not accurate. And the reasons for this discrepancy are there's quite a few, but some are that they might have had a rash when they were exposed to penicillin or amoxicillin when they were little. That was due to a virus and not to the antibiotic that they were receiving. They experienced an intolerance like diarrhea to a medication, which is not an allergy, right? It's just an intolerance. Or they did actually experience an allergic reaction, but they are no longer allergic at this point. So for example, we know that more than 80% of patients who experience a true allergic reaction to penicillin lose that allergy after 10 years. And so lots and lots of patients have these labels. In the vast majority, they are not accurate, no longer accurate. And as I kind of alluded to, and as you may expect, being labeled penicillin or beta-lactam allergic logically means that if you do have an infection or need an antibiotic, you would be much more likely to receive a non-beta-lactam or penicillin type antibiotic. But beta-lactams are the most effective and safest drugs we have for the most common and the most severe infections. And so patients with these labels receive inferior therapy when they do need antibiotics, when in the vast majority of cases, they could actually receive a beta-lactam.
Thank you. Yeah, that's a lot to take in and a lot to understand. But I think for me, sort of the thing that stands out is what both you and Raj have said, that 90% of these, labels are erroneous. First of all, how do you know whether or not they're, erroneous or not? How do you sort of figure that out? And then once you have figured it out, what is the process of removing that label from somebody's EHR?
Yeah, I mean, it first starts with history, really taking a careful history of what the reaction was, how long ago it happened. As Greg alluded to, even people who have a true allergic response, it goes away in 5 to 10 years for most patients. And so the majority of people that we see in the health system have had their, allergy label on there for decades. I was 5 and, my mom told me to stay away from it. And now here they are admitted to our health system at 65 and it's impacting their care because they can't get first-line treatment. So history is always the guiding force. And then really what we take is we take that history and try and risk stratify patients based on that history. In many cases, one of the things we found with our service, which is really fascinating, is that a lot of people, have tolerated penicillins or other beta-lactams and in their recently in just the last couple of years, but no one bothered to change the labels. So the first step that we take is first to understand, has this patient actually received one of these agents recently? And if they have, then we know they're okay and they can tolerate that and we can remove their label. And a big part of what the service does is also educate patients on the fact that they can tolerate these agents again, and that's actually a really important part of what we do is patient education. So that's always the first step. If someone has not shown tolerance to that medication, then our history guides us to risk stratify them, either as a low risk patient or a higher risk history. And for most of our patients, the overwhelming majority, like I mentioned, their history is very low risk. And our approach to those patients is we can just show that they can tolerate one dose of this agent and watch them for 1 hour. That actually effectively rules out an immediate allergic response to these medications. And so the majority of our patients, we just have to do a single dose challenge and watch them, carefully monitoring their vital signs to make sure that they're doing okay. But that's one of the key roles that our service does is we actually provide that first call in the event a reaction were to happen, which is very, very rare, that they'd be the first person at the bedside to take care of the patient, monitor them, and treat them if that happens. If someone has a higher risk history, suppose they had difficulty breathing or had, a drop in their blood pressure, something that would be consistent with what we call anaphylaxis or severe life-threatening reaction, we would then perhaps do a skin test first, which we do at the bedside. This is the same skin test that we did as an outpatient in our clinics, and we've been doing for years and years and years. But now we're taking it to the bedside while they're admitted to try and address their label at that time. And if they pass the skin test, then they would then be followed up by doing same type of oral challenge where we give them a dose of the medication and watch them for an hour. So we do all of that on the same day, and we try, if we can, based on other care that they're receiving. But we try and get that done while they're there and remove the label, and then hopefully it can have an impact in what antibiotics they receive.
Just to piggyback on some of the beginning points that Raj mentioned. So he talked about asking the patient, about the history, as well as looking at medications that they've received recently. And a lot of that information you can also glean from the electronic health record that goes back years and years and years in terms of medications they received. And one thing that Raj and I have worked on a lot is previously providers kind of across the board, whether it be physicians, advanced practice practitioners, nurses, pharmacists, didn't know that they could change those labels, right? Or inform them. In a patient who has a penicillin allergy label who just received amoxicillin, that's very important information. Safely, that's very important information. But they didn't know that they could change the record to say, hey, this patient tolerates amoxicillin, or when they could actually just remove it, the label, because they had tolerated something. And so that's one thing that we've worked on a lot, and also would like to continue to promote, which is that all providers have access, have the authority to update those records, as they find information. As a pharmacist, of course, that's something that I think pharmacists, it's a diagnosis of a drug, right? And so to me, that's something that I continually push with my colleagues, as well as for us to take ownership of informing those labels.
And just to add to what Greg said, one of the other key roles that the service has, in addition to removing the label, there are certain situations where, the label is a little bit vague. Something is just like says cephalosporins, for example, and doesn't actually highlight what specific agent they had reacted to. One of the important things that our service can do is to say, okay, if there's something that the team needs to utilize in that family, but we don't have great details about what happened or what exact agent was responsible for this. Remember, this sometimes happened 30 years ago, so it's hard for patients to recollect and to know what exact agent in this big family of cephalosporins is actually causing it. So we do challenges to agents that the team wants to use, and maybe the purpose isn't to remove the label, because we can't completely remove that label in that scenario, but we can at least clear the patient for that specific drug. And since we understand very well what other members of that family, cross-react with that target drug, we can give advice about these agents are fine, these are ones to avoid. And so it helps open up antibiotics significantly for admitting teams and patients, even if the purpose may not be exactly to remove the label completely.
And do you ever come across patients that may not push back, but they're a little scared to have this testing done, and how do you deal with that?
Yeah, definitely. All the time. We do have patients, obviously, who have a natural hesitation to do this test. And if you think about it, they've been told probably their whole life, if you take this again, it may kill you. And here we are coming to their bedside saying, yeah, we just want to give this to you and see what happens. And so there's some natural hesitation. I think what has been successful for our service has been really teaming up with infectious disease consult service. And if they're seeing these patients, usually they're laying the groundwork for why this is critically important for their care. And so we can walk back in after that's been done. And we almost never get someone saying no in that situation. So I think teaming up with the infectious disease consult service, the primary teams, to kind of stress that message before we even walk in the door is really important in getting people to agree to do it. For those patients, there's some patients who may feel uncomfortable doing it in the hospital, and that's okay. We try and see if they'd be willing to do it. If they don't, we have a process in place to see them in our clinic shortly after discharge to try and address their label in a way that they feel more comfortable. So we try and capture those patients after they've been discharged too, if there's some hesitation. And many patients are open to that. They're like, well, maybe not now because I'm still recovering from the surgery or whatever else, but I'm willing to do it, a couple of months from now when I feel up for it.
Yeah, it's both the best time and for the patient maybe the worst time to think about this, right? Because they might be here for something unrelated, right? And we're adding one more thing while they're in the hospital and they just want to deal with that one thing. And so part of this is the really outstanding education that our nurse practitioners that staff the team, Rebecca Hansen and Lauren Barheit, provide, because they, when they discuss the implications of having that and that we can remove a diagnosis essentially off your record that impacts you, not only this admission, but will undoubtedly, almost everyone requires antibiotics several times throughout their life, will impact you in the future. Then and the safety of it, which we now have our own internal data to support, most patients get on board, and the fact that we can do it now, right? That you don't have to wait until you go home and then schedule an appointment. Not that there's anything wrong with that, right? But that we can why don't we just get it done now, right? And it's not just a one-time benefit, especially for patients who may have chemotherapy coming up or transplantation or things like that. This will improve their care down the line significantly.
Yeah, definitely. I think that overall majority of people are open to doing it. There's a small percentage that are hesitant, but yeah, we try and identify patients where the antibiotic might impact them now during their hospitalization, and those are definitely ones we want to try and address when they're there. But like Greg said, there's some patient populations that we know antibiotics are going to be necessary for their future, and addressing those labels early before that becomes necessary is also an important patient population that we try and approach.
Yeah, so finally, can you explain the impact that this program has had on patients, and can you estimate, how many patients this has helped?
Sure. So our team recently published a paper where we detailed, where we explored the impact of the first year of the service. And in that first year, Becca and Lauren, our team, saw 700 patients. They were able to impact the allergy records of 94% of those patients. In the remainder was normally because there were conflicts. They had surgery, they were being discharged rapidly or things like that. So it wasn't because of failure of testing or things like that. It was because of other logistical challenges. And so in a good number of patients, like Raj alluded to earlier, they were able to impact or remove the allergy label simply by talking to the patient and looking in the electronic health record and seeing what they tolerated in the past. In about 400 patients that underwent some type of challenge, one of those sort of challenges or tests that Raj mentioned earlier, 98% tested negative. And so they're, so again, reiterating that very high rate of no longer or never were allergic. And so this has resulted in significant declines in the use of non-preferred antibiotic therapies overall in the hospital. If we just look at, for example, a drug like Astrinam, that's really only used in patients who are beta-lactam allergic, we saw significant decreases in the use of that agent in overall in the hospital. And then, of course, we've seen lots and lots of individuals benefit from these testing. And these are often, again, patients, they're in the hospital, so they have very severe life-threatening infections. And then given these numbers, given the number of patients that the service is seeing, that this also means that lots of our providers across service lines, across the hospital, ICU, floor, et cetera, now have experience with our service, which, and Beck and Lauren do a great job not only of educating patients, but they also educate providers too. And so, this not only increases the visibility of the service so people are aware of it and aware of the benefits, but also just educates about this issue and about how to safely use beta-lactams in patients who have reported allergies, about opportunities for testing and challenging. In patients who can't be tested or challenged here, they coordinate outpatient clinic appointments. And so all this, this success, and Raj can talk about the numbers since in the year since we since the first year of the study, which we published. But the team's success pretty quickly allowed us to do some other things, kind of gain the trust of providers, see this experience, so that we've been able to roll out several other initiatives to tackle this problem. Recently, we implemented a policy that gives our operating room pharmacists the authority to optimize surgical prophylaxis according to our beta-lactam allergy guidelines that has resulted in a 50% drop in the use of a non-preferred antibiotic in these patients and instead receiving a preferred first-line beta-lactam. And so there's been quite an impact both on the kind of individual patient level as well as overall metrics in the hospital that we should be able just to improve upon as we go forward and see more patients.
Yeah, and just to piggyback on that, as far as numbers that Greg, talked about our first year numbers and our success, we're approaching now 2.5 years, over 2.5 years, and now we have over 1,900 patients that we've seen, and of that, almost over 1,500 of those have had their allergy label changed or removed. So that's just a great sign that the service has continued to do well. And the remaining 400 patients, like I mentioned earlier, some of those patients, we can't test for whatever reason, they're pending discharge, so we arrange for outpatient follow-up. But a significant percentage of those patients are patients where the goal wasn't necessarily to remove their label, but was to kind of get them onto the agent that the team really wanted them to get on and to do a challenge to that agent. So that's, the success is just of the service has continued and grown from that. And I think a lot of that success has to really do with the fact that, like Greg mentioned, we have 2 amazing nurse practitioners who work on the service, Becca and Lauren, who really do a great job communicating to the patients at the bedside about this impact. So I think that part is critical to the primary teams and to the consult services about the fact that the results of the challenges in our evaluation. But also, one of the things that I failed to mention earlier is that we also communicate these results to outpatient providers, so their primary care doctors after they leave their hospital. So we really want to impact them even after they leave the health system in order to have as much of an impact as possible. And they follow up with the patients as well. And they say, hey, you were just challenged by our service, a couple of weeks ago. We were just following up to make sure there weren't any sort of issues that happened after you left the hospital. So there's a lot of follow-up work that they do on top of the actual bedside work that I think is just as important. And I think has been a key reason for the success. And I think the other thing that I want to highlight from what Greg said is the collaboration between our service, infectious disease, and the inpatient services has been wonderful. And I think people now are looking to our service when they see a patient more and more that has a beta-lactam on their chart.
Just to highlight that really cool part of it that I think is really impactful is the communication part to pharmacy, to the patient, and their outpatient providers in pharmacy. Because if you think about it, we could test a patient or we could change their label in their record in the hospital. But as Raj said, if they've been told their whole life or they believe their whole life that they're allergic to something and we just change a label and at the very least don't educate them about it, then the next time they encounter the healthcare system and someone asks, and we remove that label, the next time someone asks them that question, they say, I'm allergic to penicillin, it goes right back on, and all that work was for naught, right? And so that education to the patient, clearly making them, helping them to understand this change and that it's now safe, and that correspondence to their outpatient providers and pharmacy is really crucial to prevent relabeling, inappropriate relabeling, which in our study was a lot lower than it has been in some other programs.
Yeah, I think that's such an important point. I know every time I go for an appointment, they say, here's your list of allergies. Is this correct, right? And then it's up to the patient to say yes or no. So I think that education component is so big. Thank you so much, Greg and Raj, for sharing this robust information. I couldn't believe how much has gone into this initiative and the success that it's had. So I applaud both of you for sort of, guiding and shepherding it through its first few years and how much success you're having. If you want to learn more about this important service, go to mmheadlines.org. That's mmheadlines.org.
All right, it is time for the lightning round, when we ask one of our guests 4 quick-fire questions. Raj, you lost a jousting match before the show, so you're in the hot seat today. Are you ready to go?
Sure, I should work on my jousting before I came on here.
That's true. You didn't know that that's what was going to take place. All right, so this past weekend was the NFL draft in Detroit, and more than 700,000 fans made it down there during the 3-day event. First of all, did you go down there? And if not, what would you say is the biggest crowd you've ever been a part of?
Oh, I did not go down. I really seriously thought about it too, about going down, but I couldn't for work. But, and then I decided, that kind of a crowd I'll probably stay away from. The biggest crowd has to be the big house, right? Going to the football games here at 110,000 people watching games. So that would have to be my biggest crowd that I've been around. But yeah, it was quite an amazing event. Detroit did an amazing job hosting that event.
Okay, with the warmer weather finally having, we think, arrived for good, what is your favorite warm weather activity in Michigan?
Well, I'm a runner. I go outside and I run quite a bit, so that's my thing I do when I'm outside. I get my little vitamin D and UV light exposure that way. So that's kind of what I do most days. Well, yeah, most of the days I'm out there running at least a little bit. So that's my activity.
Now, is that better warm weather or cold weather?
So I can't do cold weather running here. I have a treadmill in my basement. That's where I go to when it starts coming around October until about now, and then
Yeah.
then I'm outdoors trying to go out there. So.
Sounds good. All right. Now, earlier this week in headlines, there was a great story about an art exhibition at the Rogel Cancer Center with some paintings. So let's put it this way. Are you an artist in any way? And if not, are there any types of art that you particularly appreciate?
Oh, I am definitely not an artistic person whatsoever. That gene definitely skipped me. Some of my family members are. My daughter is very, very into art, but I can't say that I know much or a connoisseur about this at all. But definitely, I enjoy going to museums and seeing oil paintings, sculptures. All of them are all great. So, but definitely, I'm not an artist by nature.
Okay, finally, May is Mental Health Awareness Month. What is your favorite way to wind down after work and protect your mental health?
Yeah, that's a great question. I'm glad you're asking it. Obviously exercise is a big one for me too, but one of the things that I've started to do more and more is just taking a few minutes to just sit quietly and meditate, even if it's for 5 minutes to kind of get my breath back into line with myself and kind of get myself calmed down. So I try and make that a concerted practice every day. It's helpful when you're dealing with a busy clinic and you're running 45 minutes behind, which doesn't happen all the time, but sometimes it does. And it's sometimes helpful to take a few minutes at lunch to kind of just reset yourself before the afternoon begins. So I try and do that. Helps with my mindfulness and I think helps reduce stress in the moment. So I think that I encourage everyone to consider it if they're not doing it already.
Yeah, that's great advice to just step away for a minute, right? It doesn't have to be that long, but just give yourself a break from whatever it is you're doing. Thank you so much, Raj, for playing along with the lightning round. Thank you, Greg, for sharing the information about the allergy service. If you want to learn even more about it, go to mmheadlines.org.
While you're there, you can check out other featured stories from this week. For instance, there was a look back at Patient Experience Week and a great video featuring the previously mentioned art exhibition currently on display at the Rogel Cancer Center. Find those stories and more at mmheadlines.org.
All right, Bailey. Now, we asked Raj if he had gone down to the NFL draft. I know you're a huge Lions fan. So did you make it down there to Detroit? And if not, what is a huge event that you've gone to?
I did not either make it down there, but it was very incredible. But my biggest event probably would be a Lions related, the playoff game this year against Tampa Bay. It was definitely the loudest crowd I've ever been to. So probably that one. What about you?
Yeah, so like Raj, I go to a lot of Michigan football games, so you got to put that up near the top. The draft seemed like way too many people like that. I would have felt so claustrophobic in there. But I did it was really cool. In 2008, I lived in Chicago and I went to the election night celebration in Grant Park for Obama. And that was just like an incredible moment in history. And to sort of be a part of that. I don't know what the numbers were in terms of how many people were there, but it felt like it went on for miles and miles and miles. It was pretty incredible. So I definitely have to go with that one.
That one wins, I think. Okay, it's time for the weekly trivia contest. First, congratulations to Melissa Clive, who correctly named Eid al-Fitr as the holiday that marks the end of Ramadan. Melissa, a member of the Department of Communication, will be in touch shortly to help you claim your prize. Now, this week's question is, what award ceremony served as the highlight of Patient Experience Week? What award ceremony served as the highlight of Patient Experience Week? You can find the answer in this week's headline story, and once you know it, you can send it to headlines@med.umich.edu for the chance to win a prize.
That's all the time we have for today. Thanks again to Raj and Greg for joining us, and thanks, as always, to all of our listeners and viewers for everything you do for patients, families, and each other. We'll see you next time.